Assalamualaikum, salam sejahtera. Good afternoon, everyone. Welcome back to our episode Sense with Science. This is a real, passion project. Adiba and I have started together with Karen, our moderator. So we just want to welcome you. We hope that you will engage, ask us questions in the chat box, and we will try to answer them. Over to you, Adiba.
Assalamualaikum and good afternoon, everyone. And I think this is our sixth session, if I'm not mistaken. A lovely way for us to spend our Sunday afternoon with you. And for those of you who've continued to join us, thank you very much. We've spent the last 5 episodes talking all things COVID, of course, and in the last few dedicated the sessions to the vaccine, which some of us here have received. So Karen, Tan Sri and I thought, what should we talk about this time? And I think we realized that there is a lot of anxiety in the community, not just around the vaccine, but in looking after our elderly mothers, parents, elderly sisters and grandparents and so forth. So who better to have on the show today than my two wonderful colleagues at UMMC and the Faculty of Medicine. I've been told you can only see my forehead or something. Professor Shahrul Bahyah Kamarul Zaman. We're not sisters, but we might as well be. And who's currently also the Deputy Dean for Postgraduate Studies at the faculty. She's a geriatrician, along with her other very able colleague, Professor Tan Mo Pin, also a geriatrician. So we thought they have spent the better part of the last year and a bit looking after elderly patients, either suspected of having COVID or with COVID-19, or making sure that those patients who end up at our hospital or who are being cared in nursing homes around UMMC free and safe from COVID, as well as the carers. So that's going to be what today's session is about, along with we still can't escape discussing vaccines, especially for the elderly. So over to you, Karen.
Well, hello and welcome, ladies, professors. Thank you for being with us on Sense with Science. And so, as Professor Adiba has said, this evening we're going to be tackling a very specific and vulnerable part of Malaysia's demographic, the elderly. And our show today is going to zoom in on how to ensure the safety and health of our aged folk and our warga emas in this time of COVID, and the roles geriatricians play in keeping them safe and healthy. But before we get into it, however, Professor Shahrul, or Shahrul, Dr. Shahrul, can I ask you to give us a broad overview of what caring for an aging and older population entails? In 2022, it was estimated that the share of the Malaysian population aged over 65 years stood at 7%. Now, Malaysia is currently facing the prospect of becoming an aging population, with statistical data predicting this to start happening as soon as 2030. And an aging population is defined as one in which those aged 65 and above make up at least 15% of the total population. So according to a statement by Malaysia's chief statistician in July 2019, the 15% threshold will be crossed in 2030.
Thanks, Karen. It's certainly what we call global aging and its impact. So what the overview is, I think is all quite broad. And it hasn't changed since we've started speaking about this, perhaps nearly 2 decades ago, and just up to a decade ago. I mentioned about there needing to be, and still to this day in 2022, we're still talking about the same things. The impact of global aging really looks into the need for that being the social on 3 thrusts, really: social, economic, and the environment. And for there to be for us to overcome the impact of caring for an older and aging population, you need stabilizing elements. So we need the social environment, we need the social fabric of our community to be aware and to be educated about the needs and how older people transition into being well, then frail, then dependent. We need the economic backup because aging costs money. And right now we're talking about costs to caregiving, cost to your insurance, your healthcare, cost of having multiple medical ailments, cost of hospitalization, cost of nursing homes. All this has risen, and we're still talking about the need for policy. And this is aging, may also seem like it is a public health emergency because we need for these stabilizing elements to be there. And with the advent of COVID, not just healthcare, but technology, the law and policies that actually help and enable older people to live independently for as long as possible need to be there. So I call it our C strategy, the social, economic, and the environment still need stabilizing elements that we could work better at in trying to get older people the care, the attention, the assistance they need, well, we need as we grow older in the Malaysian population. So yeah, it still is something that we are discussing, but I hope in the very near future becomes law and policy and regulated, because it's becoming quite a problem. And what we've seen with the year that we've had, costs of healthcare rises, and when healthcare doesn't come in, when it's not supported in an emergency like this, we run into problems, and we have quite a backlog of older patients needing really quite acute care and attention.
So my mother is in the very capable hands of the very laudable geriatrics team at KLGH. We made the switch to public health care after the geriatric specialist who first attended my mom left to the UK to further his specialization. So one thing I know for sure about the geriatrics team at GH is how hard they work, because there are so few of them. So Professor Tan, can you give us an overview of geriatric medicine in Malaysia? Perhaps a ballpark figure as to how many registered geriatricians there are in the country, and how that equates to how many patients per geriatric specialist.
Yeah, basically it's woefully inadequate. We've got 50 geriatricians looking after 3.5 million people over the age of 60. So thankfully, we think most of them don't necessarily need a geriatrician. What they need is a doctor who's had some training in looking after older people. So that's so we have to actually tackle this a little bit differently. So we will train more geriatricians, and I think the target figure is 350 by 2030 when we become an aging nation. So that the ratio of that will then match the ratio of the UK, which is 0.85 per 10,000 older people. But that means that most older people will never get to see a geriatrician. And so we really need to upskill our primary care services. We need to upskill all our other medical specialists, our surgeons, to actually be able to do some of this, contribute towards some of this care for older people. But the more important thing we have is preventive healthcare. Older people have to stay healthy. That's your main solution. You can't expect to be dependent and expect people to look after you. So they really need to work hard at vaccinations, really need to work hard at exercising, eating the right things, staying sharp, socializing, and mutually supportive. So all that needs to be done, and we've got 10 years to do it. So you might think it's a long time. I think it's not much time. So let's get going.
It's quite shocking, actually.
Karen, may I jump in?
Yes, please.
May I jump in? You know, although these two work with me, we very rarely meet up to talk about these things. So I'm going to take this opportunity because I'm starting to reach that geriatric age as well.
Oh, by far.
So when should we start this preventive care? Because I'm completely into this preventive healthy aging thing. I'm gonna, once COVID is over, I'm giving up infectious diseases because I'm going
Yay,
to.
get you to champion aging.
Yeah. So when
Okay.
should we start, Mopin?
Well, I think aging is a process that starts when you're born. So as soon as possible is the answer. Now.
Hear that, Jim?
Now, yes. We can't wind back the clock, but we can definitely start now.
I'm the oldest in this group, so you're making me feel really terrible right now.
Oh, no, no, no.
Oh,
You need to
well,
just get
No,
going.
not at all, Dr.
No,
Jim.
no, but I'm really glad that, you know, we have women like you who are leading the science of geriatrics. So we're very fortunate. I think you hit the nail on the spot. You know, geriatrics is so important, and especially when we're facing a pandemic like this. We've seen the effects of COVID-19 or any, you know, infectious disease on the aging population. So I think it's so important that, you know, we understand better the impact on older people.
Can I just ask, Professor Tan, why is it that there are so few geriatric specialists in this country? Is it because it's a very unsexy profession? Is it because it is a huge field of study? It takes longer, and you need a particular emotional skill set in order to be an effective geriatrician? What's the trigger here?
I think Shahrul probably can answer that question a lot better than me, because I mean, I was actually received my training in the UK, and I don't know whether it was me or what, but UK is now, geriatrics is now by far the most popular medical subspecialty in the UK. So there is something in it, but
Yeah.
why it's not catching on in Malaysia, I think Shah knows
Well,
better.
I'll answer that.
Actually.
Well, I trained in the UK too, but I came back at a time when there was a total void of the knowledge of what geriatrics was. So I'm glad I came home when I did. I came home in 2002. And at that time, there were probably, I was part trained at that time. And then there was 3 geriatricians who had a special interest. So they were physicians who had a special interest in geriatrics. And of course, they had sort of gleaned some, a lot of experience abroad, etc. So they brought in the concept of what geriatrics was. And this is in the early 1990s. And by the time I came back in 2002, we had a specialty, but there was only 4 of us. And being the only girl, we needed to sort of expand on what geriatrics was about. And it seemed like everybody over 60 was already old. So we had to sort of change the perception of what aging was. And then we realized belatedly in trying to teach and sort of create an awareness amongst even our physicians, colleagues and surgeons, etc., of what geriatrics was, we realized that nobody really knew what we did and why it was important. And that the reason behind that was that it wasn't in our curricula. It wasn't in our undergraduate curriculum. So medical students were not trained, not across all the universities, on what aging means. What's normal aging? What they see before them was just a pathology, and that all people were treated the same. And there were no sort of specialized need to manage or treat older people differently, because there wasn't this whole sort of super specialized interest in it at that time. So the curriculum was one thing. And then secondly, of course, because there were so few of us, we were the first academic trainers to sort of bring in the more of the healthcare of how to approach the management of an older person whilst in hospital. And of course, as you know, older people don't present in the same way as a younger person. So if an older person has a heart attack, they may not necessarily complain of a chest pain. They present with maybe they're drowsy, they're off their legs, they're sort of confused. So it took a lot to actually try and get, you know, the fraternity to understand where older people are different. So those of us that trained abroad kind of had that had in mind, but as we grew, thankfully, you know, now from having people forget to come to our clinic, we have long waiting lists to try and come. But the danger of this now, from the evolution of when I first came home to now, or what's going on, is that a lot of geriatrics is seen to be more tertiary level, specialized, when it actually should be in the community. And any primary care physician, any nurse, anybody with an interest in aging, any allied health professional should know what it means to to what aging is, how important it is to prevent certain diseases that may accelerate or attenuate your aging process, to live well, to live healthy, and to be independent. Because God, if you only look, we have Hari Raya coming up. I'm quite interested to see what Petronas Hari Raya ad is going to show, whether it's of an older person that's living alone and eating alone, etc. Because that perception is aging needs to change amongst Malaysians. I think aging is, as you say, should be sexier than it is.
All right, so we decided to dedicate this issue of censored science to the care and protection of older persons, because we all know how potentially devastating COVID could be for these very vulnerable members of our society. And Prof. Adiba has, she asked whether she's shared very heartfeltly about how difficult it was for her to take care of patients with COVID. And what I would like to ask is, perhaps the two geriatricians can share your specific experiences with elderly COVID patients.
Yeah. Well, to be honest, older people should not get COVID. I think that's the bottom line, because it affects them so badly. So what we're seeing is that an older person, if you're over the age of 75, your risk of getting severe COVID is 180 times more than someone below the age of 25.
Wow.
So as soon as we know they've got COVID, we don't let them out of their sight. We kind of leave them in hospital and watch them like a hawk, because they can deteriorate very quickly. And the thing is that they stay in hospital for a long time, and the risk of not making it is also high. It's getting better because we know more about COVID now, but the risk of dying if you're over the age of 75 and catching COVID is something around 15%, which is very high. And you really don't want to take that risk. But the worst thing is what it does to your body, because the risk of actually needing intensive care treatment and the risk of prolonged oxygen requirement, and after that, being needing to be discharged with oxygen, physically being very weakened by the disease and taking months and months to get better. It's heart-wrenching, because it actually literally tears family apart, because they tend to get it together as well. So you have a family with several older people with COVID, and it's devastating, because when you have that, invariably some of them don't make it. And we also see them in nursing homes. Sometimes we have 100% of the residents catching COVID, and it's really tough, because you do expect at least one or two of them not to make it, and then the rest, some of them stay in hospital for a long time, and it's quite tricky then to discharge them back.
Prof. Tan, can you repeat that again? 180 times higher in which age group?
In the over 75s.
Wow.
So that's Malaysian data. It's actually from the first 8,000 cases. We've analyzed the results and actually published it in the Lancet. So it's actually very high. Yeah, I don't think people realize how much more it affects older people, which is, and it's shocking.
Yeah.
But the mortality rate is actually over 300% higher.
If I may add, COVID is very much focused, the vaccination programs in all our various countries that have been involved played such a great focus on older people. And I think one of your questions earlier was, why is COVID so dangerous to the elderly? It's because it can be missed. It's because, for two reasons. One, older people don't present with the typical high fever. They don't present with typical symptoms of cough, etc. They may just become very weak, very tired. They may lose their appetite. And often this is not seen as a COVID symptom. So if you're in a nursing home, for example, quite dependent, etc., you may just stop eating. And then the pneumonia comes and sets in. And then by that time, things become quite advanced, which is why Prof. Tan was saying you have a much higher mortality and see quite the dramatic admissions that we've had. But if you are aware And if you're well and you're living in the community, the reason why you ought to be a bit more careful is the same for much for younger people too. If you have multiple underlying diseases, if you're diabetic, if you're obese, you don't move around, you're not very healthy, you're not eating right, you will have those symptoms. And if you're elderly, because you tend to, it's like like your CV, you accumulate more accolades with age. You tend to have more diabetes, and if you're diabetic, you tend to have high blood pressure, ischemic heart disease, high cholesterol, etc., etc., and that sort of increases your chances of having a lowered immune system, is what it is. And what we call it is immunosenescence. As you get older, your immune system has lower capacity of fighting back as well, which is why, I mean, COVID aside, older people are more at risk of getting flu and pneumonia late in life, which is why we advocate annual flu vaccines for older people, the shingles vaccine, etc. So it's about that really. And but with COVID, everything is a lot more sort of quite dramatic because they don't present in the typical fashion, and therefore there is a need to protect.
That is scary. That is, how come we don't know that? I mean, it's really very shocking to hear something like this, especially since I am one of the caregivers for an aged person. Why is it that the older folks don't present with the same symptoms of COVID as a middle-aged person or a younger person, Professor Shah?
Well, it's not just COVID. As I said, if you're an elderly diabetic and you've got coming in with a diabetic emergency, the younger person may present with symptoms and able to say things, but an older person may have what we call a delirium.
Okay.
They may become confused, etc. Hence, that part of the history taking doesn't come in. That information doesn't come in. So that then it's an atypical presentation. And with an older person, they don't usually have just one medical issue.
Sure.
One begets the next, and the next is like a domino effect. So you may come in with a pneumonia, but you go home with a heart attack, or etc. So it's more dramatic, which is why we geriatricians, right, Mopin, we work in a team. Doctors within the team can't dominate it. It's usually, our allied health professionals, our various colleagues that actually help feed in, and of course, working hand in hand with the infectious disease team. And and especially in this time, it really helps to bounce back ideas as to how we tackle this pandemic in older people. And I think, Prof. Adiba, we were in the first wave of the task force, and it was a concern that when we had really dependent older people coming in from nursing homes, that it was a concern as to how best to treat them, because they were dependent, and when we put them in an isolation room, they could feed themselves, they couldn't attend to their basic needs. So there was a need to actually try and get the nursing side of things a lot more better managed, etc. And now I think we're doing very well, and that with a multidisciplinary kind of management of COVID. And yeah, I think we're better able to handle it. And I think Karen, you were saying that not many people know about it. It's actually not very many people knew about COVID in the beginning.
That's
so
true.
Along with other specialists like the cardiologists, the hematologists, and alongside the infectious disease physicians, we were still learning about this and how it presents in our own sort of. It's not just the problem of the infectious disease physicians, right, Prof. Adiba? It's a team. It's everybody should know about COVID and know how to manage it in those. And I think the very big issue is the primary care physicians that are out there. They need to know what to expect, how to tackle it, who to channel the vulnerable older person with COVID or other things too. And,
Okay, well, obviously there's a lot of people who are tuning in right now to Sense with Science on Facebook. There's a question, very interesting one. I think it's more policy based. So Dr. Jim, this one is directed to you. This person wants to know, please share the government's plans to ensure older adults who are in the categories of immobile, frail, living with disabilities, including dementia, are successfully complete the COVID vaccination process. And where do we access the information? That's one part of the question. The second part is the challenges of going to a vaccination center and the difficulty, especially if that person is like me, a caregiver to somebody with Parkinson's who's physically and not able to go, a person with dementia who might be very traumatized by the having to wait in line and things like that. So Dr. Jim, can you take this one, please?
Yeah, thank you very much. Those are really, really good and important questions that we have actually been discussing in the vaccine task force to see how we address this. First of all, register on MySejahtera or the website or whatever you want to use. And the minute that the age comes up, it's flagged up as a very high risk, high priority group, right? And then you will be offered a vaccination site. If it's not suitable, get back to us. There's an email that you can write on the Vaccine COVID website, or feel free to contact us in any way possible. And right now what we're exploring is a couple of things. One is, if people are in elderly care homes, we may send teams to the homes themselves and vaccinate all of them there. And we'll do this in partnership, obviously, with GPs, with NGOs, and so on and so forth. We've also started to look at how we might have a drive-in facility for some people who may be immobile, who may be disabled, and who may fall into those groups that you mentioned. When we looked at the US models, it may not be as suitable here because we get thunderstorms and things like that. So you start doing things as a drive-in, you'll get very, very wet. We will try some hybrid options, but there could also be options where we can come and offer that service using our GPs or NGOs. So we are very acutely aware of this one of the special groups that may need special attention. Please be in touch with us. You can contact us through the MySejahtera app or through the website, JKJAV website, and we will try and help you as best as possible.
Dr. Jim, there is also another question. I knowing you as I do, I feel very secure every time I'm given this kind of considerations from you when I hear these things. But people on the ground don't feel as secure. They're still angry. They still want answers. They're still ringing hospitals and not getting responses. They are still sending help desk messages, not getting responses. So, like the person who has asked this question on Facebook, what happens if my elderly parent has already gotten COVID because they haven't got their immunization in because something has failed in the system? Is there a way to expedite asking for vaccination for a very at-risk person?
Yeah, I mean, listen, I can't obviously stop people feeling upset, but what we can do is try to address some of your needs. So as I said, we come on every Sunday to try and address this. There is an email you can write to us as well. You can also reach me on social media if you want, and I promise that I will look into it. I'm going to drown myself in work right now, but I'm very concerned, right, about the elderly population. As far as the older age groups are concerned, they come in immediately in phase 2. So that starts very soon. We anticipate it towards, the 3rd week or 4th week of April. But this is their planning because, we are waiting for vaccines to be in constant supply and enough, so that we can also do the second doses as well. So I can only assure you that they are priority groups. If they do catch COVID, right, or have caught it before, they can still be immunized. And we will still encourage people, whether they're young or old, to get the immunization as well.
Okay, that feels you just set yourself up for a lot of social media outcry and pleas, Dr. Jim. You know, I know you can do this, but you're not a superwoman, and this is scary. Okay, but
no, there is a JKJAV website. I'm not saying you can contact me directly. There is a vaccine COVID on Twitter. It's on Facebook. There is an email. You know, if you go to the Vaccine COVID Malaysia website, everything is there. And there's a large team now looking at all these emails every day, combing through the messages and making sure that we try to not miss anyone out.
okay. A person with dementia, you know, so difficult to get them out of their comfort zone. They might get, you know, physically aggressive. They might get emotionally traumatized by being taken out of a place, and you know, and getting jabbed, basically. You know, how do we deal with something like that, professionals?
Often, this is a much asked question that I get asked in clinic, you know, because you cannot pencil in someone with dementia into an appointment book and say, arrive at this time or you'll miss your jab. We allow for, within our memory clinic service, patients to come in and out and walk around, etc. So again, this will pose some challenges. However, like with, you know, any sort of disability, there needs to be a lot of planning. There needs to be anticipation that things may happen, and sort of to give perhaps a time period. And for those who are the vaccination team, they need to be aware that this can happen with older people. Perhaps have primary care physicians or people who are who know about managing older people in to brief at certain vaccination centers where you're going to attend to quite vulnerable people, and to anticipate these issues, and also to warn caregivers that this might happen, because they may be quite docile and happy at home, and then the minute they see a crowd, they see needles, they see, you know, different, so that might change when someone is cognitively impaired. So, you know, it's to be prepared for anything, to perhaps be flexible with timing, to prepare for quiet rooms, especially with people with dementia, because you cannot place them in a very, you know, bustling kind of area, because that might actually trigger them being upset, being more confused, more disorientated, and then become agitated. So it is really being sensitive to those things, as you would in a younger, really vulnerable group as well, if you were vaccinating children, for example.
Correct.
I think it calls for a lot of a concerted effort, because actually we have people who know how to manage older people with dementia, and at the moment they're probably not used to capacity because of this COVID. People are not sending the older people to daycare, you know, so these people can be utilized to actually manage this group. And there are even older people who are, I know from international efforts, some older people need to be admitted to get vaccinations, and so be it, you know, because they are the ones who are really going to really, I mean, what's an overnight stay in hospital compared to, you know, 2 months, 3 months stay and real severe disability afterwards. So it's really a really heavy investment on a group that's particularly vulnerable. It sounds ridiculous, but it is not, because they stand to gain so much more. Yeah, they have so much more to gain. So we really need to focus on this group. And I think I'm sure our government is invested in this. And what we really need is for people to register, because we don't know about you until we've contacted you. And we can't contact you until you have a contact. You've actually given us your contact details.
Yeah, Prof. Tan, that is such an important call. And indeed, you know, for the doctors or who are out there, you know, if they're watching this, or if you have friends who are doctors, also opportunistic vaccination, right? You've got to make sure that if somebody comes to you for hypertension or diabetes or another problem, you please ask them if they've registered, help them get registered. And, you know, as you mentioned, if they need to be observed in hospital, we'll have to find a way to do that. And if they can't come to us, then we'll have to find a way to get to them. I have volunteered to be a vaccinator, so I'm one of those who's going to be thrown out whenever, you know, there's a problem. So don't be surprised if I end up knocking my door on the elderly care home or someone's house to give you a vaccination.
Oh, you have my mom's address, right, Dr.
So if there are people like me out there who are nurses or doctors, please
my God.
register as a volunteer
Volunteer.
vaccinator.
Yeah, and we know we've had geriatrics, people with specialist geriatrics gerontology special training who actually know are vaccinators. So, you know, we do have the expertise to know how to manage all these things.
When the next phase does come along, perhaps when we were talking about concerted efforts, that, you know, we could come in with the as part of the planning to sort of to anticipate these potentially problematic, to troubleshoot scenarios that might occur, etc. And you know, the NGOs that look after older people with Alzheimer's, the care homes that know and have caregivers that manage older people with dementia, etc., and who are dependent. Those are the people that would be the resources. Yeah.
We'll be calling both of you and the NGO as well.
So we walked
Delighted to
into
help.
that.
Yeah.
Yes, definitely.
Just give me a tray full of vaccines and I know where to take it.
Oh, that's dangerous.
So homeless people who are older, because sometimes on the streets you see people who are homeless who are older age group. So we're working with NGOs to register them, and you know, we want to wait for those homeless people. We want to really wait for the single dose vaccine because you know, one of the challenges NGOs tell us is that we don't know whether they'll sleep in the same spot the next day. It's very sad. But this is the reality, right? So we've got to start, you know, being flexible and adaptable and tailoring some of our responses as well.
So, Dr. Jim, when you're saying the single dose, you mean the J&J vaccine then? The one shot?
Yes, there are two vaccines only that are single dose, and that is Janssen, which is by Johnson & Johnson, and the other is CanSino. So we've got CanSino on our portfolio waiting for it to be approved by NPRA.
Okay. Well, since this is really great, the people who are listening in or viewing are really interested in this, and they're really happy to have two very seasoned geriatricians on with us. There is a question, Profs. My mother is 78 years old with a history of Stevens-Johnson syndrome for the past 7 years. Is she eligible for the COVID vaccine?
Everyone is eligible, provided that it totally depends. So you have a pre-existing condition that would render you vulnerable to a reaction. So we must anticipate that she may well have a reaction. So these are the sort, and it depends on how severe the adverse, the reaction she had with each with each exposure or trigger. So to anticipate that, then we would need to sort of make concerted efforts to actually prepare her for this, get the doctors engaged, and perhaps even an admission. It depends on what the response was, whether it was a severe reaction, etc., and what were the triggers before, and to ensure that she's in the peak of health leading up to the vaccination, and making, you know, putting all your ducks in a row to prepare for an event that may very well not occur, but we have to be prepared. So whether it's Stevens-Johnson's, whether it's, you know, you've got quite severe asthma, whether you've got chronic lung disease, whether you've got, you know, multiple other problems that you're concerned about, it's to anticipate, prepare, and ensure that the support system that would ensure that you, if anything were to happen, that there is someone at hand to help you out. And this is where, you know, assuming that the older person has a caregiver to ensure that the caregiver is aware of all that. But if for those who live alone, who are older, then to ensure that, whether it's a neighbor, a friend, or a support organization that could identify. And this brings about the importance of community and neighborliness with amongst all the people who live alone, etc. In this time, which is where a lot of my older patients who haven't yet registered and they're still waiting to see what would happen is because they feel that they don't have that support network in the community. So that's kind of one of the things that, so what if anything happens to me? What if I have fever? And I said, well, it's about a balance between you having body aches, fever, and being unwell and taking paracetamol and resting at home, or actually catching COVID and having very adverse events from, and potentially dying with COVID. So at the balance of the fear of vaccination versus, and having those side effects. And my, a friend of mine in the UK had a vaccination and had severe body pain. And I went, well, did she get better? Did she rest? Did she have paracetamol? And so, yeah, she got better, but it's that fear. So we've got to remove that. And there will be certain people who have pre-existing conditions. They're the ones that need to anticipate, potential side effects. But what side effects? What is the balance of that side effects? Yeah. How severe it is would depend on, the condition is a very, very case to case. It's about preparation. Yeah. And to remove that element of fear, because if it's fever, body ache, maybe having a little bit of a cold, or even potential something but it's treatable, it's reversible. It may not be as devastating as catching COVID and needing respiratory support. So that balance needs to be had, and I think that's where a lot of people in the community are still at. And some of my patients in clinic are asking, well, should I, but I'm not prepared to to go through that. But I say, well, what are you not prepared to go through? Because getting COVID would be worse.
I thought just came to me.
Sorry.
Sorry, Adiba. Carry on.
Go on. Okay, if I can jump in there, I think specifically around, I agree with all of what Shah has just said in terms of, allaying the fears and reassuring a still rather large proportion of the hesitant public, fearing the side effects. But specifically around the two most feared and severe side effects, namely the anaphylaxis reaction, where you get the trouble breathing and swelling and a drop in blood pressure, and that the association for that reaction is more with the mRNA vaccines, and the Stevens-Johnson's, which for those who are not familiar, is you get kind of severe blistering of the skin and the mouth, etc. So I think those are the two most feared, and you really, really need, when you register, you really need to inform us or the My Sejahtera, the forms, that you have those two reactions. And at present, I think MOH, those are the two what's called contraindications for the vaccination program. Yeah. And specifically for the anaphylaxis reaction, because of higher risk with the mRNA. But I think, perhaps for those who are at risk of severe COVID, the killed vaccines might be okay.
Yeah, I was just going to touch on that a little bit, Karen, because on the Stevens-Johnson syndrome, I would exercise real caution with this, right? So they need to get their physician to look at them, really get a detailed drug history and so forth. I think one of the biggest challenges we have, of course, is that the primary vaccine we have right now in the country is Pfizer, which is the mRNA vaccine, and it comes in a vial for 6 people. So you can't I can't take one dose and then run to someone's house and jab them. So I think this is where, this whole question around community is so important, right? If, for example, UMMC has a center, I understand you have a center for the elderly patients, that they can then be gathered there with some activity for the day. and that then becomes, you know, a place for them to have the vaccination together with, like, you know, very similar age group people, to give them a bit of confidence. And I think once we start vaccinating, if we got some of the older people vaccinated, we got to get them to come out and speak about it and share their experience as well.
That's very true. I think having peer-to-peer reaffirmation of certain things, like, hey, you know, I've taken the vaccine, nothing bad has happened, that is going to make a very, very big difference to the number of older people coming forward willingly to be vaccinated. Definitely. Okay, so the two biggest issues caregivers deal with in keeping their older dependents safe and healthy is the elder person's stubbornness in sticking with their routine. You know, they want life to be exactly as it was pre-COVID, and then the converse, the absolute turnabout phase, which is the fear that COVID might instill in an old person, this crippling fear, so that they no longer want to go out. They no longer want to take their walks around the park. They no longer want to do things outdoors because they are so incapacitated by this fear. So how would our two professors approach this in their capacity of advisors to the caregivers?
It's too broad to actually deal with in general, but I mean, it really depends why they need to stick to a routine. So particularly our patients with dementia, they thrive on routines, and most people struggle to actually get them to stick to their routines. So with COVID, it's bad news, because suddenly they can't do their routines, they can't go out for their walks and things like that. So what we advise these people to do is to straight away snap to a new routine, and then invest a lot of effort on that new routine. But there are older people who feels insecure outside their routine, and you know, it's very difficult to manage. And the last thing you should do is to make it an issue. So they tend not to listen to you anyway. I mean, if anything's to go by, my father will never listen to me. So the thing to do is to actually get them in a peer group that will actually talk about these issues, and actually help each other address these issues, and give them motivation to use alternative means of communication. So my father's birthday came quite soon after the lockdown, so we actually had a party, a Zoom party, and then all the sisters and everything came, and then he went, oh, even those outside Malaysia, they can dial in. Normally they can't come to my birthday, so they can see an advantage in those sort of things. So yeah, new things. Yeah.
And the other part you mentioned about, you know, getting them engaged. Now, the way in which an older person engages has undertaken many challenges during this whole time. And if they're used to certain patterns, certain routines, a lot of it is taken away. What we see is often a decline. So the mental stresses, the depression, the further isolation is quite palpable amongst our older senior citizens. The importance of engagement with the community, with your neighbor, and if you're part of a family network, to actually bring in the young and the old, because I think the connection that we've had is via technology in this instance, and those who engage either physically, mentally, socially is so important for all three to go on, because those who are not physically able, they need social stimulation. If they can't go out, how do you get them engaged? So it's whether it's a matter of putting in a timely phone call, getting people together online, dropping by, but maintaining social distance. And with that particular question that you had about the father wanting to go and meet up his friends in the kopitiams, I think the thing here is when you sort of try and stop someone from doing what they want, then a lot of negativity comes in. And I think it depends on the relationship you have with your parent. I think it's probably more the ability to negotiate and giving options which may vary their social calendar, and insert yourself in that to sort of vary that engagement, and getting the whole family involved in that. And I think it's been so important
So
to
I think
many
Karen,
older people.
sorry, Karen, it's really important to encourage the older people to meet outdoors. You know how older people like taking walks.
Yes.
We know that it's much safer in a well ventilated space or outdoors. So I think, that could be an option. If I could please try to answer Lulu Go, and maybe Adiba can help me as well. Lulu, you asked a really good and important question, and the question is: when we seniors are chosen to go for phase 2, we just go on that date, and how will we know it's safe for us if we have some history of cholesterol, high blood pressure, etc.? Will the nurses and doctors have a chat with us, and before administering the vaccine and so forth? Okay, first of all, if you have all those what we call comorbidities, it becomes even more important for you to be vaccinated. High blood pressure, diabetes, hypercholesterolemia are not contraindicated, which means that you can still take the vaccine. When you fill up those forms, yes, it just shows that you have to just tick off what you have. You don't need to write your medication. When you come to the vaccination center, the staff there, the nurse on duty or the doctor will speak to you, get your consent form. And, if you have any questions or any fears or any worries, ask. And then, you will then be moved on to the vaccination site. So it's not like you come and no one's going to talk to you and just get a needle in your arm. No, it's going to be quite interactive, and that you have a chance to ask questions. So please don't worry about it, Lulu.
Oh, that's really, really nice. I think that goes a very far, it goes a very long way, Dr. Jim, to be able to have somebody senior to say these things to you. And I think that's one of the best things that has come out from Sense with Science, this engagement to the people at ground level. And it's fantastic. So
Maybe Prof. Adiba, University Malaya has a fantastic vaccination center, which I visited with the
Thank you.
minister. So
Yes, we have a lot of people,
that's right.
including medical students and nurses and doctors, to answer your questions. But I think, in the last few months, it has occurred to me that there is this bit of confusion around, if you have comorbidities, meaning high cholesterol, high blood pressure, cardiac problems, is it safe to be vaccinated? Versus, well, actually, if you have those things, you should be vaccinated, because that increases your risk even more, just beyond the age factor. And if you put, if you include being overweight as well, then that increases the risk further. So if you have more than one, comorbid condition, it increases the risk for severe disease. And if I may repeat, the only contraindication or the reasons why you should not be vaccinated are what we talked about earlier, the anaphylaxis reaction and the Stevens-Johnson type severe allergic reactions. Everything else, talk to your doctor about it, and chances are it will be safe for you to be vaccinated. In fact, you probably be in the risk group to be vaccinated and should be vaccinated as soon as possible.
thank you so much, Prof. Adiba. All right, so another viewer wants to know if there is truly a higher chance for older folk to catch COVID as opposed to other people. And if that is so, why is that?
I think Prof. Tan, you mentioned it earlier. Maybe you can repeat that. And Adiba, I think is best placed also to answer.
Yes, there are certain groups of older people who are at higher risk of catching COVID. So we know that particularly in the long-term care in nursing homes, because that you have a lot of older people in the same place, and many of them are either physically debilitated or have memory problems, so they don't remember to cover their mouth when they cough, and it can be very difficult to get them to wear face masks in common areas, and they don't have the ability to wash their hands as much as possible. So COVID spreads very, very fast in those sort of environments. And then, of course, we have had issues with in sometimes they come to hospital a lot, they have appointments a lot, so that actually increases their exposure as well. But the main place is actually in nursing homes, and we have had huge numbers of outbreaks in the West. So I've just swatted up on the figure. In the US, 40% of their deaths were from long-term care. And in some countries, like Canada, 50%. So it is actually quite, it just spreads like wildfire in a care home. And it's nothing, it's nobody's fault. It's just the way it is.
That feels so sobering, honestly, Professor Tan. You know, I mean, I get that's just the way it is, but it is so frightening, and so in a sense it feels really, really daunting, you know, especially if our older folk are already feeling a bit insecure about getting vaccinated, right? And
Yes.
and they hear these things and they're like, okay, so it's either I die of COVID, or I might have some adverse reactions to the vaccinations, you know.
Yes.
But can we just clear it up right now to tell the older folk who are tuning in, who may be tuning in, if there are really more risks associated with vaccinations for the elderly than there would usually be for younger people?
Well, actually, we don't, we can't answer that
Yeah.
that very clearly because we haven't really got all the statistics. But what we can tell you is that 98% of all the older people living in care homes in Scotland, 98%, I was so astounded, have been vaccinated, and UK-wide 95%. And what they've seen is a reduction, just one dose, because you know there was issues with the second dose in the UK. So after one dose, reduction in COVID deaths in care homes, 57%. And what they're seeing now is it's reduced by nearly 90% now with the second doses. So Israel hasn't really given us nursing home figures, but we know that Israel has actually vaccinated more than half their population, and we have seen remarkable reduction in hospitalization and deaths with COVID vaccination. And we haven't seen, the UK has not seen any really severe adverse effects from their vaccination efforts. And it really brings to question what all those scare stories were about in other parts of the world, because they were successful in vaccinating 90% of their older population and 95% of their long-term care population.
The difference is in Malaysia, most of our elderly people live with their families. And I think this is why, you know, for those of us on this program and those who are listening, or your friends, please get your parents, your aunties, your grandfathers and all that, you know, registered to be vaccinated. It's more tricky here because they're not in one place, right?
And the reason why it spread like wildfire was because a lot of care in nursing homes, it was also the lack of PPEs, the close ventilation, the seasonal variations in these countries. And of course, we have similar concerns here, but the higher numbers that are there were what negated the need to do this very, very effectively and very, very fast in the UK. For us, with our nursing homes, there is a challenge in that, you know, we need to actually get them all in a very cohesive system that would actually offer protection information, you know, PPEs, actually giving them the awareness about the importance of SOPs. And I think many of those that have been registered, correct me if I'm wrong, Maupin, that when you engage them, they were very, very keen to sort of adopt these SOPs, etc. But I think there needs to be further discussions, engagements on how they manage the care homes in the best way possible, because hygiene standards, food standards, etc. I mean, immune systems of the older dependent older persons are lowered anyway. And if you're in care homes that are not to certain standards, this may be further impaired, which is why there is a huge need to protect older people within nursing homes, but those in the community are equally vulnerable. And you know, it may seem very daunting, but it is just a matter of maintaining hygiene, wearing your mask, maintaining distance, SOPs. They should eat right, move, keep moving, engage mentally, physically, etc. Keep healthy, and go outdoors. Just don't go to crowds. And you know, life as they know it may happen. You know, may come back to normal as sooner uh, with you know, with more people getting vaccinated in time, but it's just getting to that stage. We need to be very careful about negating the fear factor here, and the reason for this is to actually to get, we have lots of tremendous mortality figures abroad, but we've kind of been quite lucky here in Malaysia. And if we put ourselves in the figures of mortality abroad, that might sort of create more fear. Then it's a whole different kettle of fish. We have similar concerns, but I think, as you say, that there's a lot more older people living at home, and they too need to know what to do, what not to do, really.
Yeah, that makes perfect sense, Professor Shah. I think you and Professor Tan have really shed a lot of light on what needs to be done. There's been a lot of good counsel. There's been a lot of really positive output from both of you, and we thank you for that. Have we, in our questioning, in our lines of questioning, have we negated to ask anything that you feel as geriatric specialists to be of particular interest or importance to caregivers for the elderly who need to push the vaccination agenda?
Norway question. Whenever we talk about the elderly, the Norway, those who died in Norway often pops up. Karen? Yeah, I think there was something like 23 deaths in Norway earlier on, back in January.
Right.
And, you know, just to put the question to rest, I hope. So it was extensively investigated by the Norwegian Health Authority, and no causal links to the vaccination was found. A lot of these patients were already terminally ill and very, very elderly, and it wasn't because they were vaccinated that they died.
Yeah, I think that's a really important point, Adiba. You know, there's something called excess mortality that we look at, which is much more scientific. And we know that a certain age group, you know, mortality is higher. It's, you know, basically, you know, in a certain year, we expect X number of people to pass away. And we've not seen a significant rise, you know, in deaths with COVID-19. So it's just, you know, it's just unfortunate that it's you know, the person died, but it's not because of the vaccine. So causality is very important. You have to know whether a vaccine causes deaths, and so far globally there has not been shown to be any causality in terms of mortality after giving a vaccine. So it's I always have to do the terrible thing of closing the session, but just to say, Karen, wonderful moderating as always, and huge thanks to our two wonderful professors, Professor Tan and Professor Shah. You know that Adiba and I, when we started this little project, it's become a real passion project for both of us. We look forward to Sunday afternoons with people, and we really wanted to show the feminine side of science. It means women in science coming forward to talk to you. But, you know, we may break tradition and get a man on very soon. But what's really important is we hope it's really useful to the viewers. And for those who are viewing live, thank you for coming on. I know it's Sunday afternoon and people probably want to go out rather than stay indoors. And it's a nice day out today. But do share the videos with your friends and your families. But more importantly, please get your elderly friends and relatives registered for vaccination. So I just want to say thank you very much to everyone and hand over to my partner, Adiba.
Thanks, Tan Sri. Nothing more to add really, and you know, we hope to continue this series to allay fears, to encourage people to vaccinate, to remind people to continue, even though you have been vaccinated, your family has been vaccinated, to continue to practice all the necessary distancing, etc., etc., until, you know, more people get vaccinated. But in the meantime, yeah, do stay safe and stay vigilant, and do look after our golden oldies. I'm about to go and visit, having said that, I'm about to go and visit my parents this evening.
Well,
It's my ritual after the Sense with Science on a Sunday evening.
thank you everyone for joining us today. This has been Sense with Science. And until next Sunday at 5 p.m., stay safe and remember to listen to the experts. Professors, thank you for being with us, and thank you so very much for all the richness of knowledge that you shared with us. Dr. Jim, Professor Adiba, thank you for a wonderful evening again. Good evening, and we will catch you next week. Thank you. Bye.
Thanks, Sean.
Thank you.
Bye.
Bye-bye. Thank you for having us. Thank you.